and welcome to a new series of self-paced episodes that will be taking you through every aspect of immunohistochemistry. This series was meant for IHC beginners or techs that want to know more specifics about the reasoning behind IHC and also those who want help with IHC troubleshooting. This series can also assist with preparation for the ASCP's Qualification in Immunohistochemistry Certification exam, most often referred to as the QIHC. Let's get started. What are common uses of IHC? IHC has many useful applications such as clinical diagnostics, academic research, pharmaceutical drug development, and more. For this series, I am choosing to mainly focus on the clinical application of IHC. For clinical pathologists, IHC is just one tool in their tool belt of diagnostics. IHC can help determine the origin of a metastatic tumor. It can also confirm certain viral and bacterial infections. I have a couple examples off to the right of the screen. The top photo shows a slice of a patient's lymph node that has been stained with Epstein-Barr virus antibody, or EBV. The Epstein-Barr virus is commonly passed by teens in the form of mononucleosis and has been known to linger in the body for decades. Later in life, this virus can cause more complex diseases, such as lymphoma and multiple sclerosis. Underneath the EBV image, there is another IHC photograph of a stomach biopsy. This magnified area shows a diffusely infected stomach lining with Helicobacter pylori, aka H. pylori. This infection can lead to stomach ulcers, and if left untreated, can also cause gastric cancer. So you can see the importance and application of IHC to help accurately diagnose patients. IHC can also help pathologists with statistical data. Often, the pathologist works closely with the patient's oncology team to help the patient understand their prognosis and if the patient can benefit from certain IHC-associated treatments. Antibody expression in tumors can even predict a patient's treatment plan. Drugs such as Herceptin and Keytruda are partnered with HER2, NU, and PD-L1 antibodies. These are also known as companion diagnostics or predictive markers, meaning if the patient's tumor levels are above a certain threshold via IHC, a patient can receive these life-saving therapies. Before we get started on the details, I want to mention some real-life scenarios that you may run into in the clinical pathology laboratory. In this first example, let's consider a patient who was found to have a lump in her breast during her routine annual mammogram. Her physician orders a biopsy to be performed, and that biopsy is sent to the local pathology laboratory where you work. The biopsy is grossed, processed, embedded, sectioned, and then is sent to the pathologist for microscopic evaluation. The pathologist notices vast changes in the breast tissue that appear to be an invasive tumor. Their initial diagnosis is adenocarcinoma of the breast. That day, the pathologist orders subsequent IHC testing to check the hormone profile of this tumor. Estrogen receptor, progesterone receptor, and HER2 NU markers are ordered in the system. These marker names are commonly shortened to ER, PR, and HER2. The pathologist reads the IHC slides and determines that the patient's hormonal tumor profile is ER negative, PR negative, and HER2 strong positive. The pathologist orders additional testing of HER2 fluorescent in situ hybridization, aka HER2 by FISH, to be done at an outside laboratory. The strong HER2 positive is confirmed by strong HER2 signal, seen here in red, compared to the normal CEP17 gene seen here in green. With this confirmation of IHC and FISH expression, the pathologist can now recommend Herceptin treatment, which works by binding to the overexpressed HER2 protein on the surface of the tumor. A second example can be seen on the lower half of this slide. Let's say a patient presents in the emergency room with severe abdominal pain, swelling, and shortness of breath. The emergency physician orders a CT scan of the abdomen and chest. These tests reveal several very large tumors in the liver and lungs. A needle biopsy of the liver is performed. The biopsy is sent to the hospital's pathology lab and is again grossed, processed, embedded, and sectioned. Here's a glimpse at the H&E slide where the pathologist notes large areas in the liver invaded with a tumor. The pathologist orders a CD31 and a Ki67 immunostain. The CD31 reveals diffuse vascular activity, and the Ki67 confirms advanced cell proliferation, which indicates a fast-growing tumor. These results, along with the cell morphology from the H&E slide, help the pathologist determine that the patient has small cell lung carcinoma. This type of cancer is almost exclusively associated with patients who smoke. These are just two examples of how important the job is of the clinical histologist and pathologist. You are making a real difference in someone's course of care and overall disease prognosis. What exactly is IHC? Well, IHC can be explained as a laboratory technique that allows us to visualize proteins that reside within tissues or cells. These proteins are too small to be seen by the human eye, even under the microscope, so we must find a way to make them larger. Using IHC technique, these proteins, or more specifically, antibodies, are made larger. You will hear this process referred to as amplification. This will allow us to be able to see the localization of the protein in question under a microscope. I'd like to start out by focusing on antibodies, which are essential to this process. There are thousands of antibodies to choose from, each of which have their own unique application. Each antibody has an attraction or specificity, most referred to as affinity. The variety of antibodies you might see in your laboratory fridge or on vendor websites are the very things that will be binding to a target epitope, aka the protein of interest that the pathologist wants to see. The epitopes in question can exist inside, on, or around the cell of interest. Take CD3, for example. The CD3 epitope exists on the cell membrane of T cells. Ki67, which is another commonly used antibody, will bind to the Ki67 epitope inside the nucleus of proliferating or multiplying cells. Certain epitopes can exist in a combination of multiple localizations. CD10 exists both on the cell's membrane and inside the cytoplasm of certain T follicular helper cells. Another thing to note is that antibodies specifically bind to site epitopes that fit their unique shape. This affinity is often compared to a lock and key fit or a puzzle piece fit. As you can see from this visual example shown below, the top of the Y portion of the antibody, aka the Fab region, is the receiving lock, while the epitope is the fitted key. In a future episode of this IHC series, I will get into more specifics of antibody structure and function. How are samples prepared for IHC? I'd like to briefly discuss the pre-analytical steps of immunostaining. I will have a separate presentation on this subject alone. However, I'd like to mention the most important parts. Since we will be talking about one kind of antigen retrieval step in the next slide, I should mention the precursor to this step. We all know that 10% neutral buffered formalin is considered the gold standard fixative in the clinical pathology laboratory. It's a wonderful fixative, and it helps preserve the structure of tissues. However, there are downsides of aldehyde-based fixatives. One of those downsides is cross-link formation. Cross-link formation is excellent for tissue stability. However, it is prohibitive for epitope accessibility. In order to proceed to perform IHC, we must first loosen or break those aldehyde crosslinks. You can see in this animation below, this structure represents a tertiary protein. This could be any protein inside tissue. What happens when 10% neutral buffered formalin is added? These tiny bonds form, which stabilize the structure of the tissue. Now, look at the animation on the right side. You can see the formed crosslinks. There's just one problem. When we perform IHC, we need to get antibodies inside these tight areas, but those crosslinks are blocking our way in. In the next slide, I'll show you how we get around this, or more accurately, through it. You will hear this process referred to as antigen retrieval or antigen unmasking, and can be done with heat, steam, acidic solutions, basic solutions, or even with enzymes. In the research setting, Some scientists will try to debate that time in formalin doesn't matter, and that is true for some proteins. Maybe they exist out here on the edge of the protein. However, if the protein in question exists inside here, we are never going to be able to reach it without the antigen retrieval step. CAP, or College of American Pathologists, really stepped up to defend this theory. Now, certain specimens have a time limit in formalin due to this very issue. If you look at a pathology report for breast tissue, the total time in formalin is documented by the tissue grosser. So, moving back over to the technical side, where exactly do antibodies bind? I'm a visual learner and thought it would be best to explain what is happening with an illustration. In this example, we will be looking for the protein human epidermal growth factor receptor 2, or HER2-neu protein, which can be expressed on the surface of breast cancer cells as well as on the surface of gastric carcinomas. HER2 testing performed via ISH and IHC still remain excellent predictors of responsiveness to HER2-targeted treatments in breast cancers. We will go over a specific patient example in the next slide. So, in this particular IHC example, we start with a breast biopsy sample. That breast tissue is placed into formalin, grossed, and processed normally, sectioned, and mounted onto a charged slide. Here is the slide. This little brown blob is representative of the tissue slice, and this little pink squiggly area represents a certain protein of interest, which we said earlier is HER2. First things first, we need to undo some of the damage that formalin fixation has done to the tissue. During fixation, stabilizing bonds have been formed from the addition of aldehydes. Applying heat and an acidic or basic solution known as antigen retrieval will undo or loosen some of these disulfide bonds and will create an entryway for the antibody. Before we apply the primary antibody, one more thing must happen. We need to block the endogenous peroxidase inside the tissue slice. Endogenous is a word that you will hear quite often when discussing IHC. It is referring to something that has originated inside the tissue. Endogenous peroxidase is a natural part of blood. In IHC, we must block the endogenous peroxidase before going forward. We do this by applying 3% hydrogen peroxide. I'll remind you why this peroxidase step was so important further on in this presentation. Now that the bonds have been broken and the peroxidase has been adequately quenched, we can move on to applying the primary antibody. Way down on the molecular level, which you cannot see in a microscope, exists the HER2 epitope. In this example, the epitope is represented by the white triangle. That tiny epitope is going to be the binding site for our HER2 antibody. Typically, antibodies are drawn in cartoons as Y-shapes. The yellow circled region is known as the Fab region, and that is the location of which the binding occurs. I should also note that this bond isn't overly strong, as it is a non-covalent bond. We will get into binding specificity and other regions of the antibody in future lessons. Okay, so what's the next step of this series of events? We already saw the primary antibody bind to the cell epitope. Next comes the secondary antibody. Now, this looks like a lot is happening all at once, but is considered one step in the IHC process. This entire area right here that I'm circling with the pointer is a more modern method of antibody detection. IHC did not start out this way, and there are definitely simpler methods. However, I wanted to concentrate on what is happening in clinical laboratories current day. So, automated IHC machines like the LicaBond, Dako AutoStainer, or Omnis, and the Ventana Ultra are using these types of technologies. And this is the type of secondary antibody conjugation that you would use in a modern clinical laboratory. In this example, I will start here with this blue antibody. Some of you may be looking at this shape and thinking, hey, why does that look exactly like the HER2 antibody? Well, that's because this is also an antibody. However, secondary antibodies are much more vague than primary antibodies. These little blue secondary antibodies will bind to any mouse IgG and rabbit IgG. These days, not all, but most clinical kits are a cocktail of mouse and rabbit secondaries. And that's because most human reactive antibodies are manufactured inside of mice and rabbits. There's a whole other world of antibodies grown in goat, donkeys, sheep, horse, and more. But for now, we will focus on the common secondaries that are used on human tissues. Back to the secondary antibody used here on the screen. This long area represents a conjugated antibody. This long white ribbon represents a dextrin backbone. And onto that backbone, antibodies from two different species are attached. Half of them are mouse antibodies and the other half are rabbit. The yellow circles are representing HRP, which are also conjugated to this white backbone. Now, if you recall in the previous slide, this HER2 antibody was raised in a rabbit, meaning the rabbit secondary will stick to the HER2 antibody, while the mouse-derived antibody will not. So what ends up happening is now this tiny epitope has HER2 attached to it, the rabbit secondary is now stuck to that, and this entire parade float of other molecules are now going along for the ride. In IHC, you can now understand why this series of events is called amplification. We're trying to take this teeny tiny epitope and somehow make it visible under the microscope, even though it is at a subcellular level. At this point in time, the float is not visible to the human eye under the scope. That is, until the next step. Here we are. We have made it to the visualization step, where all of our hard work can finally be seen. So how exactly is the protein of interest visualized? The answer comes in this next step. Just like in the last slide, the primary and secondary antibodies are represented with pink and blue Y-shaped symbols. The yellow balls, or HRP, are ready for action. Now, interesting fact, HRP, or horseradish peroxidase, really is derived from the horseradish root that some of you may use to enhance your prime rib at a steakhouse. The green blobs, labeled DAB, are the chemical compound 3,3-diaminobenzidine. The moment the DAB substrate is applied to the slides, it encounters the HRP, which acts as an enzymatic catalyst in the reaction. The 3% hydrogen peroxide is used again, but this time acts as an oxidizing substrate, helping the HRP and DAB combine more quickly. The quick chemical reactions product is a brown precipitate, which forms instantly upon contact. The brown precipitate, represented here by brown blobs, drops in the immediate area of the epitope, and that is the brown signal that you can visualize under the microscope. Remember back when I told you that the peroxide blocking step would be important? Think about what would happen here if we had endogenous peroxidase lingering around. It would encounter the DAB and form a brown precipitate. However, earlier in the process, we blocked the peroxidase with hydrogen peroxide first, rendering it inactive. Finally, the finishing touches can be applied to the slide. After the final slide rinse, an enhancer should be applied. It will change the dual DAB precipitate from a watery golden brown to a more rich, deep brown, which can be better visualized under the scope. Typically, copper sulfate solution is used for this step. Next, we will want some background differentiation or counterstain. The counterstain of choice is typically a progressive hematoxylin, such as Mayer's or Gill's. After this step, a final bluing solution can be applied. This will change the purple hematoxylin hue to a baby blue shade, which is a perfect contrast to the rich brown of the DAB precipitate. Now that that is all done, here is the final product, a beautifully stained section of human breast tissue. The cell surface of the breast tumor is shown in brown, visualized with HER2 antibody. In contrast, we have this beautiful blue background that makes the HER2 signal stand out, which in turn makes it easier for the pathologist to interpret. I wanted to conclude this presentation by mentioning that future episodes are already in the works. Remember, don't be afraid to be a forever student. There is always something new to learn. See you next time.